Hello and welcome to our Facebook Live chat. This is Doc Talk Live with NorthBay Healthcare. And with us today is internal medicine physician Larissa Chartrand. She's going to talk about preventive medicine. So take it away, Dr. Chartrand.
Hi, good afternoon, everybody. My name is Dr. Larissa Chartrand, and I practice primary care here at NorthBay, specifically in the Vacaville location. I do subspecialize in internal medicine, and for those of you that are not sure what internal medicine specifically means, it means that I specialize in the care of adults, so patients 18 years and older, and that I can manage a wide variety of cases, so a myriad of cases, as small cases to complex cases. There's really no limit to what I can see, and so that's what internal medicine in a nutshell really is. Today, we're going to be talking about preventive medicine as opposed to just your regular follow-up visits when you're going to see your doctor. And a lot of you have probably heard the term preventive medicine. Some of you hopefully know what preventive medicine is, but a lot of times when I see patients for the first time and they're establishing care, they don't really know what preventive medicine means. And so my goal is to be able to educate you as I educate my patients what preventive medicine means and why it's important. So we're going to talk a little bit about that. Next. So on this screen, as you can see, this is a report that's called the National Vital Statistics Form, and this is from 2020. After every year, down, hit enter. So sorry.
There we go.
So at the end of every year, what the CDC does, the Centers for Disease Control, will basically be a report on what the most common causes of death were for that past year. And they've been doing this for a very, very long time. I think as far as what the Centers for Disease Control, CDC, means, the good thing is that because of the COVID-19 virus epidemic, that most of you already know what the CDC is. And so when this report comes out, usually we'll look at these top 10 causes of death. Sometimes we focus on even the top 5 causes of death. But I really wanted to expand it to include the top 10 causes of death, because usually every year when I receive this report, there's one comorbid illness or one cause of death that may replace another as 3rd or 4th place, and then the next year it switches. But this year, for the first time, as you can see, there's an arrow where COVID-19 is, and it's the 3rd leading cause of death in 2020. And that's new. There hasn't been any new, there hasn't been an additional cause of death in this, 4 decades on this report. So just so you know though, heart disease and cancer, always still in the top 1 and 2, and the remainder of the causes of death as well, usually hit that list. And the reason why this is important, and why am I talking about the causes of death when I'm talking about preventive medicine, is because this is where it all stems from. After many years of finding out the causes, the top 10 causes of death, the CDC said, well, what can we do? What do these all have in common? What can we try and do so that, is there anything that we can do ahead of time before these patients end up in the hospital and end up dying from one of these causes? And the commonality that they all have, because they're all very different, is that they are all in fact preventable. You can do something about them. You can screen for these illnesses beforehand, meaning looking for them, investigating with them, whether they be through blood tests or pictures, to see if this is something that exists and you don't even know about because you feel fine. And that's what's called screening. You feel okay, but we're looking for something that might be underlying in there and hasn't woken up, and we're gonna find it and treat it before it even becomes a problem. So this tells us a lot of information about the things that we want to focus on. And in addition, it also gives us our average life expectancy. So that's why this is important. And our average life expectancy fluctuates a little bit here and there in the past 4 to 5 years. On average, it's about 79 years of age, or 78.8. For men, it's about 75 years of age, and for women, it's just a little bit over 80 years of age. And so that's where the difference comes. So just want to make sure you can see it. And so this is what we're gonna do, what the CDC decided they were gonna do about it. And now we have that information and we say that we can prevent death, so what do we do with this? And so again, the CDC decided we're going to actually create a whole branch of medicine that's called preventive medicine. And the primary care doctors, your general doctor that you go to, are gonna be the doctors that are in charge of this. And so the preventive medicine isn't just about preventing the illness, because that sounds so much easier said than done. It incorporates screening for illnesses, and that's what I was trying to mention to you in the slide before, where screening, the difference between screening and testing is, screening is you have no symptoms, but we're looking for something. And versus just testing is because you don't feel well, it sounds like it could be something, and we're doing specific tests for that diagnosis. So that's the difference in that. Aside from that, it's also reducing risk factors, and there's many different risk factors, but some of the top ones would be smoking, tobacco cessation, correct? Or obesity, trying to assist in weight loss. And the reason why reducing risk factors are important is because there's so many years of studies that show that, for example, smoking is bad for your lungs, right? Smoking can cause and is a contributing factor, one of the number one factors, in fact, that can lead to lung cancer. And so that's, sometimes we have to go down to that risk factor to help prevent illness. Again, we're talking about preventive medicine. And then last but not least is counseling. And we can use that tobacco abuse, same example, because in that case, what do? We counsel our patients. We talk about ways that we can assist them and in being able to stop smoking, and interventions and things that we can do. So those are different examples or different branches that will encompass what is preventive medicine. And so now we'll talk a little bit about who would even be in charge of this, and what tests do we even order, and what illnesses are we even going to be focusing on. I mean, sure, the CDC says, this sounds like a great idea, let's prevent this, but are we gonna have somebody that's telling us what to do? Are we gonna have a guideline? Is there gonna be some sort of uniformity with this? How are doctors gonna be able to have something to kind of follow and formalize this, as opposed to you going to one doctor versus another, and they have completely different ways to go about trying to prevent medicine. And so there is uniformity. And this is why the United States Preventive Services Task Force was created, which is what we call the USPSTF. And this was created back in the 80s. It's mandated by Congress. So yes, there is a very high level of control over what guidelines we talk to you about when it comes to preventive medicine. And it's mandated by the Agency of Healthcare and Research Quality, and which basically means that all of the guidelines and all of the recommendations that we're making for preventive medicine come from what we call evidence-based medicine, meaning years and years of studies that are considered to be well validated, that have been reviewed over and over again. And so these are the highest quality level research studies that have been conducted out there, and that's what the USPSTF will review. And beyond that, who's even in charge, or who encompasses the USPSTF? It's not Congress, it's actually various different doctors that represent the different disciplines in medicine. So it's not just primary care. So family practice and internal medicine are both part of primary care, but you also have your pediatricians, you have your obstetrics and gynecologists, you'll have psychiatrists, and on top of that, you'll even have some subspecialists that join in, like a gastroenterologist, for example. So lots of different doctors that have different training and different kind of opinions and how to focus on a particular preventive clinical service. And it's kind of nice to be able to have different perspectives and put them all into one formalized recommendation. And so all of these recommendations are based on evidence-based medicine, and these are all peer-reviewed studies, meaning they've been looked at, made sure that they are top-notch and highly validated. And there are a lot of recommendations out there for preventive services. We're not going to talk about all of them. I want to focus on the ones that are grade A and B recommendations, and I'll tell you in a minute what that means. And the reason why is because those are the ones that have the largest amounts of studies that support them in a positive way. And those are the ones that you want to know about because those are the ones that are covered by your insurance. So let's talk a little bit briefly about the grading system, because sometimes it can be a little bit daunting. But to break it down for you, grade A recommendations are the ones that have been shown to have the most significant or substantial benefit. So we know that by performing this test that we are only going to provide benefit with very little risk to the patient. A grade B recommendation is also a good test to perform. A grade B recommendation shows moderate. The grade B recommendation shows that there's still moderate benefit in comparison to the risk. So it's still definitely worth performing this test. Maybe not as substantial as a benefit as a grade A recommendation, but it's still there. A grade C recommendation, on the other hand, we will show an example of that, just kind of want to show you the difference, but a grade C recommendation is one where maybe the benefit of performing the test is small at most. Sometimes there's not necessarily benefit versus risks, and it all depends on the patient. It's very patient specific. And so in these cases, these are the recommendations that we tend to recommend to patients only when we've discussed those benefits versus risks. And so a physician should not see recommendation tests for you unless they've discussed what the benefits and the risks are. And grade D recommendations are those that showed that the risk outweighs the benefit, so those are out. And grade I recommendations, I stands for insufficient, which means we just don't have enough studies. It could be a great recommendation. Maybe in a few years we'll have studies that shows it definitely has a benefit in comparison to the risk, but we're just not there yet with the studies that we have. And so this is a very heavy slide that goes through not all the recommendations. These are just a good chunk of the recommendations that either have new updates just as of the past 1 or 2 months, and they're pretty new, and I want to make sure I give you updates on that, or they're recommendations that you pretty much get asked about or talk about on every visit, if not you should be, with your primary care provider. So this is in alphabetical order, and again we're focusing on A and B recommendations. So we start with abdominal aortic aneurysm screening, or what we call AAA screening. That's a very routine screening test. It's only indicated for men between the ages of 65 and 75 years of age who have ever smoked. And this is just a one-time test. The ultrasound will look in the abdomen to see if the biggest blood vessel that serves it, which is called the aorta, looks like it's leaking. And because if you don't necessarily feel that it's leaking, but if it's leaking, things can be done to repair that blood vessel, and that saves lives. And it's a grade B recommendation. And all of these have been relatively updated, whether it's from 2018, 2019, up until just a couple months ago. Then we have breast cancer screening. I know for women, this is something that with primary care providers, we talk about all the time at every visit. And there's a recommendation for women ages 40 to 49 years of age that shows that there is a grade C recommendation, and then there's a recommendation which shows actually a more significant benefit in women ages 50 to 74 years of age. And the reason why the recommendation has not been shown to be as strong, and it's a grade C in women ages 40 to 49 as opposed to 50 and up, is actually, and this was changed probably just about 6 or 7 years ago, there was actually found to be the net benefit of actually going through the process of a mammogram. There's still a significant degree of false positives that can come out. And that false positivity rate seems to be a little bit higher in women in this age group. And that leads to biopsies, sometimes unnecessary biopsies, again, if they're false positives, anxiety, stress, and biopsies don't come without their potential complications. Although they're minimal, they can bleed, they can get infected when that site that you biopsy. And so
ultimately, when it comes down to it, is the benefit outweigh the risk in this situation? Maybe slightly. It really depends on the person, but talk to your patient. That's what I always tell them. So you talk to your doctor. I talk to my patients and I tell them, this is, if they're between the ages of 40 and 49, I want you to make this decision. This is the benefit. We could catch something early, but there's risks that it might be a false positive, and we put you through this. And as long as they're okay with understanding, and they decide they want to go through it and they're okay with it, then I'm okay with it too. I think having that conversation is what's important when making that decision. Your insurance will cover starting at 40, which is why generally when you go to see your doctor, they'll recommend it for you starting at 40 every year. And the reason why is because even though I, as a primary care provider, follow the United States Preventive Services Task Force recommendation, there are other services out there like the American College of Obstetrics and Gynecology, or what we call the ACOG, and that's what an obstetrician or gynecologist would generally follow. They have very strong recommendations to be actually, they say the benefit definitely outweighs the risk to start at 40. And there's still good valid evidence to say that that is the case. And so because one particular group or agency has decided to say, and they have evidence that supports starting it at this age, then it's certainly covered by insurances. So just keep that in mind. Sometimes when we're recommending these tests, where they're coming from, why the recommendation is coming from, but make sure your doctor is educating you about this and that you're asking questions. So that was breast cancer screening. Then we have cervical cancer screening. It's a grade A recommendation. Everybody, American College of Obstetrics and Gynecology, USPSTF, we all agree the benefit cannot be more loud. The benefit definitely outweighs the risk to be able to do a pap smear, which is basically a specific smear that's performed with a swab of the cervical area to look to see if there are cells that can be cancerous or even precancerous, because there's a lot of interventions that are even minimal that physicians and the providers can do to be able to eradicate that before it even turns into cancer. So it's a big deal. And now we have vaccinations against HPV, human papillomavirus, which is the number one cause, or in 95% of the cases, the cause of cervical cancer. And so many things that we can do in this case. So it's a grade A recommendation. Then we have colorectal cancer screening. This one's recently changed. It used to be for many years, 50 to 74 years of age, get your screening. And colorectal cancer was, colonoscopy was really the standard of care. But now we do have a new, there's many different modalities, and I'll talk about in a little bit, but there's another modality that came out that we can use a little bit earlier, that's a little bit less invasive. And that one has been shown now with many studies that we can start to screen at 45 and there is a benefit. So that's a grade B recommendations for patients. It's a grade B, I want to make sure, grade B recommendation for patients between 45 and 49 years of age, whereas for 50 and up, it still remains a very strong grade A recommendation. This was just recommended in May of this year, so it's a big deal. Now insurances are all covering it. Have those conversations with the doctors, because now things are changing even in our own primary care office. Things have changed since that came out in May. Then we have depression screening. It's simply a two-question questionnaire when you go to see your doctor for all adults over 80. Once a year, they just want to make sure they're asking you if in the past 2 weeks you've felt sad, down, or depressed, or if in the past 2 weeks you've had lack of interest in your usual activities. And if the answer is a strong yes to any one of those, then it prompts you to ask a more detailed questionnaire, try and investigate whether you have depression or not, whether this is a problem or not, because we're finding more and more that depression is something that people don't like to talk about. It has a very negative stigma to it, but there's things that we actually can do to help treat, not necessarily just medications too. So We do screen that once a year at least. Hepatitis C is also a one-time screening. It used to be only for patients 1945 and born between the years of 1945 and 1965. And this is because there was no filtering of blood when there was blood transfusions during those years. And so there's still high prevalence in that group in comparison to the general population. But now that we have medications that have been shown to be 99% cure, we've decided, well, it doesn't matter. Now that we can cure things, we should be doing it in all adults at least once. So that's a pretty new recommendation as well. Just in your blood work at one point, be tested for hepatitis C. HIV, all adults pretty much. I see over 18, but this starts at age 15 years of age until 65 years of age. And why until 65 years of age, and why not until 75 or 80 like some of the other recommendations? Because the other recommendations are doing it based on the average life expectancy, right? That's why you hit that number. But 65 seems kind of like an odd number, but that's because they've actually shown that there's a lot of studies that show HIV patients are at very low risk of HIV at 65 years and after. So that's why we generally don't test for them unless you want to be tested or you're at risk. But remember, screening means we're ordering tests and you feel fine, and we're looking for things, not because you feel bad, right? Or because you have a risk factor. This is just for everybody. Then we have hypertension. This is when we check blood pressure. Hypertension means it's a sustained state of blood pressure beyond a period of 2 weeks, and that's a medical disease or a condition. It used to be, this also changed just about a month ago. It used to be that it was just once a year, but now it's every time you go see your doctor, check your blood pressure. And we're also incorporating not just the office blood pressure measurements, but your home measurements are very important. Then we have lung cancer screening. I think a lot of people are still surprised about this one because lung cancer screening has been around for quite some time, but it was updated just this year again. And we do have a way to screen for lung cancer. It's with a low dose CAT scan, and it comes with a high level recommendation B. And this basically is a test that's only performed on smokers because we've found such a significant tie between smoking and lung cancer. So if you're a smoker, it used to be a 30-pack year history. Now, just a few months ago, they changed it to a 20-pack year history or more. And you're still smoking, you haven't quit within the past 15 years, then you're significant risk for lung cancer in comparison to the general population. And we do low-dose CAT scans. However, if you were a smoker and you quit more than 15 years ago, your risk actually goes back down. So it's not recommended for those patients. Okay, so that was and osteoporosis. That's the last one I'll mention. Generally, women, when they turn 65, will order a DEXA scan, which is a nuclear medicine scan, to look at the mineral content of the bone. And the reason why osteoporosis is important is because it leads to risk of fractures in the hips and the spine. Those are the two we focus on, and those are associated with significant reduction in functional capacity of the patients, and reduces overall quality of life and even survival. So it's important to do that because we actually can strengthen bones. We have a lot of great medications that can actually get your mineral content back to a normal number. Okay. And so I mentioned colorectal cancer screening, that I was going to discuss the modalities. And these are all different ways. If you were to go see a gastroenterologist, these are all technically all options that you can choose between to be able to be screened for colon cancer. The reality is, though, insurance is only going to cover certain amount, only certain modalities. An example is I've had a lot of patients ask me, what about a CAT scan? I'd rather do a CAT scan than do a colonoscopy, and with a capsule and they can look inside. But generally the CAT scans, because they're very expensive, money and cost of care and cost effectiveness, it plays a huge role in anything but in healthcare system and what we offer. So really, if there's if there is still a better test out there that's more cost effective, they're still going to recommend a colonoscopy as opposed to a CAT scan, unless you have a reason that you cannot have, unless there's a reason you can't have a colonoscopy. For example, some patients are on blood thinners and you can't take them off. And so in that case, you don't want to do a procedure. You'd rather do a CAT scan. But you got to prove that. But there is a new stool-based DNA test that's called the Cologuard, and it's 99.6% sensitive, so meaning negative. We feel really, really, really good about the fact that there's nothing going on there, but it's looking for any DNA that could potentially, even in the future, lead to cancer. If that test comes back positive, it doesn't mean that you have colon cancer, but it does in fact mean that you need a colonoscopy. And there's been some studies that show actually if you have this test and it lights up as positive, and the gastroenterologist will then need to do a colonoscopy, that they actually have spent a little bit more time in that colonoscopy looking for potential polyps or potential precancerous lesions, because they know that something came back abnormal in your test. So that those are two, I think, really good options, colonoscopy and the Cologuard, and they're covered by pretty much all health insurance companies at this time. And so now we talk a little bit about not necessarily my role or your doctor's role, but your role in this. And I mentioned this because you can lead a horse to water, but you can't make them drink it. And it's very important for you to know that when you're going to see the doctor is going to be driving the ship and making sure they're providing you with the right recommendations. And if you're not feeling well, going through your concerns and problems and coming up with a treatment plan, and you should feel listened to. But make sure it's the opposite way, that your doctor is actually listening and that you are involved in your own care, because ultimately the responsibility lies on your shoulders. I can give you homework to do and say, your blood pressure's been high, check your blood pressure at home, check it twice a day, and give you the machine and order the medications, and give you a paper that even says you're going to write it in these spaces and bring it to me in 2 weeks, and we make a visit for you in 2 weeks. But if you don't check it at home, that this is only going to fall negatively on the patient. And so that's what I mean. It's important for you to be involved in your own care and be your own advocate, because you also want to make sure you feel listened to. I don't believe in cookie cutter medicine, meaning that these guidelines that we talked about are for everybody. If not, a robot would be doing my job. I think that it's important for everybody is different. Everybody's body is different, works different. Everybody wants different things and has different values and expectations and have different cultures and religious beliefs. And these are all things that I, as a physician, need to make sure I'm listening to, and you should be talking about and making sure your doctors are listening to as well, because decisions usually, even if I have two patients that are the same age and same sex and both have high blood pressure, I can guarantee you that I probably have very different treatments for one than the other. So be your own advocate and make sure that you're also voicing your concerns. So it's a collaborative process. It's between you and your physician. It's not just one way where your physician is telling you what to do. It shouldn't be that way. Again, it's your responsibility ultimately. Make sure you maintain an open dialogue, and that does require a certain level of trust. So you have to feel comfortable with your provider to be able to talk to them, not just about your health and what's wrong with that, but I mean beyond that, talking about whether it's cultural, religious beliefs that come into that and affect your decision, and also any hardships that you have. A lot of times I hear, for example, patients that want to lose weight. And for example, a mom that wants to lose weight and she's got 3 kids and she's a full-time mom and she works full-time and she just doesn't have time to cook and look into what's going to be a well-balanced nutritional meal, or she's just not going to have time to go to the gym to exercise. And that in itself is a hardship, right? We have to try and figure out ways to be able to bring that to her. And so there's different challenges for everybody. And last but not least is also going beyond just seeing your doctor, going to your local community that offers resources, on helping improve your healthcare, whether it's mental health resources, physical resources, going to the gym, signing up for the gym. That's a local resource that you can do to take care of your body and keep your cardiovascular system healthy. So that's an example of that. And then shared decision making. This is a specific method that is being introduced into the medical school and training and doctor training. Shared decision making is basically, it's been around for a long time, but now it's about allowing the patient to be able to have a say in their own care and feel like they're being heard and be able to be a part of the decision-making process. And we've found for many years now that this does improve the satisfaction of care that the patient receives and the quality of care that the patient receives. When you make decisions together, it's two brains, it's going to be the most effective treatment plan, I guarantee you, as opposed to just the doctor telling you what to do or you thinking that you know what's best and not listening. So it's a team effort is what I want to say. And this is actually now how I train a lot of medical students. I've trained residents throughout the years, and this is now how we are training our residents. They come in with us to these patient visits, and they actually see that we involve them in the decision-making process, because usually there are options. And so these are the applicable circumstances. Almost all the time it applies, but sometimes there is just one answer. Maybe surgery is the only answer. We got to get that thing out, right? In cancer, for example. But a lot of times we do have options, even when it comes to medications. We can choose a medication that a lot of times there's side effects. There's always side effects to medicines, but one medication might have a desirable side effect for you than it would for another patient. For example, a muscle relaxant. Sometimes I have patients that cannot sleep at night because they pulled their back, it hurts a lot, and so they actually want a muscle relaxant that's going to help them go to sleep. So I'll choose one that actually has that side effect profile of making you feel somnolent or sleepy, as opposed to some patients that I gotta go to work and my back hurts so much at work because I pulled my muscle, and so maybe giving them something that doesn't make them sleepy that can get them through the workday. But those are two completely different people. And also thinking about the cost. That's also very important in being able to decide between medications and tests, for example. So everybody has different values, everybody has different preferences, but the patient, you have to make sure you're communicating that with your physician, or else they're not going to know. So I think that's about it for my lecture. Overall, I just wanted you all to have a sense of what preventive medicine means and what the role of the provider is, what your role is, and how important it is to come together to be able to make the best decision for you, for the patient, because it is about the patient. Medicine now is focused on patient centricity, and that's how it should be.
All right, we have a couple of questions that have come in during your talk. Loma is asking, how do you go about getting these screenings?
Yes.
Does you wait for the doctor to call you, or you call them?
So I'd say definitely, again, be your own advocate. Call the doctor, and make an appointment to see your primary care provider. And if you have an established care, or if you want to get just screening and preventive testing performed, there is an exam. It's called the annual exam, where every year you focus on that, and your insurance company wants the doctor to focus on all of those specific tests that are recommended based on your age, on your sex, on your demographic that you would be applicable for. So I'd say don't wait for the office to call you. You call them and make that appointment.
How often for pap smears, and up to what age?
So pap smears start at 21 years of age now, and they go up until the age of 65 years. They can be anywhere, if they are normal, they can be anywhere from every 3 to 5 years, and that just depends on whether that provider has a special DNA detection test for human papillomavirus, HPV, because I don't know if you remember in the lecture, that causes 95% of the cases of HPV related cervical cancers is from that. So it depends on which test modality they're using. Usually most providers at this point have the HPV DNA. So as long as your pap smears are normal, it's every 5 years. If your pap smears are abnormal, it depends on what the degree is, and that changes the surveillance time drastically.
Okay. And regarding HPV vaccination, is that for young people or is there an age cutoff for that?
Yes. So for the past 3 years now, HPV now has been, the vaccine Gardasil has been expanded now to women up to the age of 45. So kids do get it. Generally, that's recommendation has been around for quite some time under the age of until the age of 26 years of age, actually starting from 11 to 26 years of age. But now women between 26 and 45 years of age can also get this, and it is covered by your insurance.
Okay. We also had a couple people asking about the COVID vaccine boosters. At this point, I believe NorthBay is just offering it for the immunocompromised, and they need to talk to their doctor about that. We don't have much more information on boosters, do we?
No, unfortunately not. We're following what the FDA says, and the FDA earlier this week on Monday did meet, and they decided that when it comes to the general population, there still wasn't enough evidence to say that we were going to provide it for everybody a booster. But the only approved one is for those that are immunocompromised. And talk to your doctor to see if you qualify for that if you have questions or concerns.
And somebody's following up on the HPV. Do you get the vaccine for boys too?
The vaccine for boys is actually not given. This is for girls because even if men can get HPV and can carry it, their risk of penile cancer is slim to none, like 1 in a billion. Incredibly enough, what it does is it can cause cervical cancer. It just likes the cells in the cervix. So it's recommended for women.
Okay. Are there some things that preventive medicine can't help? I mean, your genetics are your genetics. Are there some things that you can't prevent?
Oh, absolutely. Unfortunately, there are a lot of things that we just can't prevent. When I showed that slide on the top 10 causes of, I want to show you the top 10 causes of death. I brought this up because we know that since this is what's causing the majority of deaths in the population, we want to make sure we're focusing on this. We know it's going to be cost effective. And now for so many years, we have a lot of studies that focus on trying to prevent these. So there's a lot of medical illnesses that I see that are outside of this spectrum that may contribute to causes of death, but we don't necessarily have screening tests for them.
Okay. Well, we've reached the end of our time here. We do want to let those who are viewing know that our next Doc Talk Live will be on aortic aneurysms with vascular surgeon Melissa Loja. That will be at 10 a.m. on October 13th. So tune in then. Until then, thank you, Dr. Chartrand. We appreciate it.
Bye, everybody.